Hello everyone and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander people listening today or in the future. My name is Rebecca and I will be facilitating today's webinar, which is on integrating hepatitis C testing and treatment into addiction care of people who inject drugs. Lessons from Melbourne's medically supervised injecting room, presented by Acting Professor Nico Clark. This webinar is part of a series of Connect and Learn webinars designed to support AAD clinicians throughout Victoria. We do like our webinars to be as interactive as possible, so we've allocated time at the end of Nico's presentation for questions. All of our webinars are recorded and are later made available on the Turning Point website. However, we won't be recording the question time, so feel confident that you can talk and you won't be recorded, and please feel free to ask any questions you like. At the end of the presentation, please, if you could, take a few minutes to complete the evaluation survey using the QR code, which will be on Nico's final slide, or via the email that will be sent to you later today. I'd like to introduce our presenter. Acting Professor Nico Clark is a specialist in addiction medicine and the head of addiction medicine at Royal Melbourne Hospital, clinical director at First Step Clinic, adjunct clinical associate professor at Monash University, and principal research fellow at the Burnett Institute. Nico has a strong commitment to improving health outcomes for people who inject drugs. He has played a pivotal role in advancing integrated models of care that combine hepatitis C treatment with harm reduction and addiction services. Nico, thank you so much for joining us today and making the time to present to our sector.
Thanks, Rebecca, thank you for that kind introduction, and thank you for the opportunity to share this experience with you today. And hello to those who are listening, and recognize some old friends in the crowd there. Thank you for joining today. So I'd like to share a little bit about our experience in the injecting room primarily, but about our attempts to integrate hepatitis C testing and treatment into that kind of harm reduction setting, and what that might mean for those of us working in the addiction sector who might come into contact with people who injected drugs, and where there's the opportunity for testing and treatment of hepatitis C. So I think I'd like to start just with a moment's reflecting on like when we think about addiction treatment, what are we really trying to achieve? I think and I say that because when the name is addiction treatment, I think sometimes our job is to treat the addiction or to stop substance use or reduce substance use, but we are dealing with people who have complex stories, sometimes a range of things that affect their life experience, their life satisfaction, their health, their well-being, their chances of being alive, and people's substance use per se is only one part of that. But if we think into more broadly in terms of some of the objectives of drug treatment services, we're also looking at reducing drug-related harm, improving mental functioning, improving physical and mental health and well-being, social functioning, quality of life, helping people live longer. And so for many of these, addressing hepatitis C is a key influencer of what we might consider the outcomes of addiction treatment. And I say that by saying I think it's well and truly something we should be thinking about as part of our role as an addiction treatment providers. So why hepatitis C in particular? If we look at the impact of viral hepatitis globally, it's having actually it's one of the major causes of death, if not the major cause of death globally in people who inject drugs. Increasingly, it's hepatitis C is now a bigger problem than HIV. HIV is kind of coming down now because of the big investment in diagnosing and treating people with HIV. But we haven't to date invested so much in viral hepatitis treatment, in partly because the treatment can be expensive and has been expensive and still is quite expensive. But it's the alternative of not treating is also really expensive when it results in liver cirrhosis and liver cancer and the spread of viral hepatitis to other people. So we're now at a situation where we have the tools to eliminate hepatitis C globally and in Australia, and we have a choice. And if we follow the things that we can do to eliminate hepatitis C, we can really dramatically reduce the amount of hepatitis in circulation in our community. If we don't do those, then they may stay the same or may even continue to increase. There is a global movement around the world, and particularly Australia is very keen to play its part in that for its own population of trying to eliminate hepatitis C as quickly as possible, and with the view that we can really not only improve the health of people who have hepatitis, but we can dramatically reduce the amount of money we're spending. There'll be some initial increase in spending, but then we have the possibility to have a dramatic reduction once we reduce the amount of hepatitis C in circulation. So what's currently happening with the kind of diagnosis and treatment of hepatitis C in Australia in people who are attending drug treatment services. So if we look at the kind of access cohort, which looks at people in the drug treatment sector, of those with an opioid agonist treatment prescription, we can see that when this was at least most recently done, there are a lot of people who have either not been diagnosed or they're diagnosed who haven't been treated. See, the majority of people, we got 2/3 are HCV antibody positive, and the majority of those were PCR positive in this study. But there's many of those people didn't receive direct acting antiviral treatment. So we can see that there's a big drop off between the total number in treatment and those who've received a test. Less than half in this cohort had actually received any testing, and again, less than half of those who are RNA positive had. Only about 2/3 who are RNA positive had received a prescription. So based on this, there's a lot of opportunity to improve what we're doing. There have been some studies looking at the prevalence of hepatitis C virus more recently, and it varies a little bit in the setting. From I think that study that shows it was about 45%. It's come down from that period of time. In most needle and syringe programs, it's about 12% RNA positivity. So it's come down from 18% even just 5 years ago. In prisons, it's come down a lot due to efforts of testing and treatment in prison, and it's kind of about 15% in people who've injected drugs in prisons. And in the hospital emergency departments, for example, it varies, but in our hospital, it's about 13% of people who've injected drugs in the emergency department have Hep C RNA positivity. So it's not hard to find people, if you look amongst those who've injected drugs, who still have hepatitis C, who could benefit from treatment. So I'd like to now share a little bit of the experience that we had identifying and treating hepatitis C in the injection room. This is a picture of the facility at North Richmond Community Health Centre. And part of the objectives of this service was and remains to reduce hepatitis C transmission, both by the provision of sterile needle injecting equipment, but also by the testing and treatment of hepatitis C. So I'll share a little bit now about the kind of the evolution of hepatitis C testing and treatment programs in the Community Health Centre. So this is a kind of aerial view from Google Maps of the Community Health Centre. And what you can see on the left-hand side here is uh, uh, where the injecting room was initially when they kind of built a temporary facility, and it's just like 20 meters away from the GP rooms, which were at the other end of the community healthcare centre. And so the initial plan was to refer people as after they used the injecting room to walk in the front door of the community health centre, go and make an appointment with the GP, get a blood test, get treated in that way. They're kind of the way our health system is designed. What we found is that so here's a close-up of the facility. People would come in, they would use the injecting room, they'd stay around, have a coffee. They might have we had this little consulting room on site. We would say, are you interested in doing something about your hepatitis? And they say, yeah, I wouldn't mind. And then they'd go around to the GPs at the community health centre for follow-up. So this is again our standard practice, and we had North Richmond has some GPs who are very experienced in this area, who've kind of worked with population of people who've injected drugs for many years, and they would kind of refer to the pathology nurse there who would take the blood. They would go back for an antibody result, and then if the antibody was positive, they would get a PCR test and again go back to the GP for the result. If they were PCR positive, they might be referred for a FibroScan or assessment of cirrhosis, which was required for the treatment, and that could involve referral to a specialist centre at a hospital. And then you would get your medications from a community pharmacist, typically with a small co-payment involved. And this is, in a way, the way our healthcare system is designed. And while this might not be complicated for most of us, the reality is that each of these steps involved requires a degree of organisation that can be a challenge. Even making an appointment with the GP can be intimidating for some people who are not so good at that, and particularly for something like hepatitis, which doesn't appear to be a pressing issue. Most people don't feel so bad with their hepatitis that it's on the top of their list of priorities for that given day. So no surprise to many of us that very few people who we thought were really keen to get tested for their hepatitis C actually got as far as getting tested in that model. Which we asked people about the barriers to accessing hepatitis C care, that people would say that, either not knowing where to go, the cost, even though the cost is not substantial for the user, the cost of $30 for a prescription or even less if you have a healthcare card, is still a barrier. The way that people perceived they were being judged by staff, the challenges keeping appointments, or even just the kind of the convenience, the fact that people have to travel, other concerns. So we thought, well, let's see if we can design a simpler system. And so in partnership with the St. Vincent's Department of Gastroenterology, we designed a simpler system where basically we would take blood in the injecting room, consulting room, and organize a prescription, and that they could come back and get that prescription filled. So it could be as little as a two visits through the injecting room. The first time we would take blood and ask some questions, and the second time we could give a prescription. We'd do the PCR test up front. We developed a non-specialist treatment pathway, telephone consultations with specialists when needed, and minimize the number of consultations prior to initiating treatment. And we would supply the direct-acting antivirals directly rather than giving people a prescription to go and pick it up at a pharmacy. The non-specialist treatment pathway was a partnership with the Department of Gastroenterology, which treats hepatitis at St. V's, that for a segment, and it's about 80% of people, were a kind of simple hepatitis C treatment cases. It was it was a first treatment episode, there was no cirrhosis, no HIV or Hep B co-infection, no significant drug interactions with Mavorite or Epclusa, the two medications with the kind of pan-genotypic medications we would prescribe, and people were not pregnant. And So if people met this criteria, we could initiate the either Mavorite or Epclusa. If they failed any of these criteria, we would have a conversation with the Department of Gastro, and then they may or may not need to see the person. But if they didn't need to see them, they would send a prescription, and if we could have a telephone consultation, we'd do it that way. And so this minimized the number of consultations substantially. Yes, so just a little bit more detail about that first, the non-specialized treatment pathway. So assessment of cirrhosis, we could do a number of different ways. We could do a FibroScan. Sometimes we had a FibroScan on site. You could do with the APRI score, the AST to platelets ratio index, which is an approximation of fibrosis, or you could even do clinical assessment. I mean, the reality is now with these medications, the presence of cirrhosis didn't make a huge difference to the duration of treatment. In the past, it's often meant an extension of treatment time. In order to minimize the number of consultations prior to initiating treatment, we would gather as much information as we could on the first consultation if possible, so that we would be ready to provide a prescription on the second time we saw somebody. This would be the standard kind of script for the testing. So you'd need to do some full blood liver function, Hep C, antibody, and PCR. Medicare only pays for the PCR if people are antibody positive. So you need to send blood for both, so that if the antibody is positive, they immediately do the PCR. HIV and Hep B, serology, INR, UNEs, and we also added syphilis serology, and we had the occasional positive from that. In terms of the treatment, we would either prescribe Epclusa or Mavorite, largely without any evidence that one's any better than the other. One is 1 tablet daily for 3 months. Mavorite's 3 tablets daily for 2 months with food. And we'd ask people which one they think they would manage better. And then in terms of evaluation, we would repeat the PCR at 12 weeks initially post-treatment. Now there's kind of a move towards doing it only 4 weeks post the cessation of treatment. And then annual PCR testing of ongoing risk behaviors. And so this was a kind of simplified approach. This is kind of basically what's in the guidelines for the treatment of pangenotypic treatment of hepatitis C viral infection, produced by Australian Hepatology and Gastroenterology Society of Australia, if you want to look at those. So this meant that when people came into this facility, we could basically do this in this little consulting room you see there in blue off to the side. If we had a doctor there, either one of the doctors from the community health centre or myself, and people would come in, they would use the injecting room. We would take blood if they were happy to have hepatitis C testing. We'd send it off for PCR testing, get a prescription, and then store the prescription, store the medication on site, and then when they came back in, we would give them the medication. So this simplified model over a couple of years already, we rapidly scaled up the number of people that we were treating. So over 2 years, we treated screened 321 people in this way, of whom 45% were positive at that time. Now the rate has come down, and the 85% were able to be initiated on treatment. We didn't have the data so much on what happens to people if they didn't follow up, but of those we were able to follow up, there was good outcomes and very good satisfaction with that treatment approach. But we thought we could do better still with the evolution of and availability of point of care testing. So again, when the new facility was built, we integrated a point of care testing machine. So this is a GeneXpert point of care testing machine, which can give a very accurate result within 60 minutes based on a fingerprint blood sample. And so that had the advantage not only of giving the result on the spot, but also that you didn't need to take a whole blood sample if it was difficult to get a whole blood sample from somebody because their veins were not very good. So in this model, and this is a kind of bird's eye view of the purpose-built injecting room, where people would come in the entry area on the left, go into the injecting room area in blue, and then go through to the aftercare area on the right in the yellow again. We integrated hepatitis C testing. Sometimes in this little room off the entrance area, we could do a finger prick sample, or sometimes then we put a PCR machine actually in this room with the bed there, and sometimes we'd have a fibroscan there as well, and so we could test and diagnose within 60 minutes, and people sometimes waited around for the results, or sometimes they came back a little bit later and got the results on the same day. And then we could courier the prescription down to we send a prescription down to the pharmacy, and they would courier the medication back, and we would store it on site. Either give it to the person straight away or store it on site for them to come and pick it up the next time that they're in the facility, or later that day or whatever. So this approach was piloted largely through the PhD of Michael McIsaac, and in his first 9 weeks, we were able to kind of test and treat almost as many people as we had tested in the previous 2 years. So we screened 228 people, of whom 28 were RNA positive, 28%. And almost all of them were able to get an initial prescription for direct antivirals, and very good outcome in that cohort. So overall, after 4 years, combining these, we tested more than 1,200 people. Kind of overall RNA positivity of just under 30%. Actually quite low rates of fibrosis, and pick up the occasional hepatitis B and HIV, and initiated kind of 280 people. So there were some people who we weren't able to follow up, but less than we were able to follow up more than we saw was kind of in the drug treatment cohort that Access presented more broadly. This kind of simplified model was kind of generally well regarded by the people who were receiving treatment, saying that previously it had been a barrier getting a whole blood sample for testing or treatment, and that they definitely thought that people should be offered hepatitis C testing and treatment coming into the injecting room. And almost everybody was either satisfied or very satisfied with the point of care testing process. So that remains the kind of, I think in the time where I was there, we kind of became the main testing and treatment place for in Victoria, and it remains a kind of option for people attending the injecting room today. And again, you see people kind of very happy with that model of care. So what if we were to kind of apply this model, what can we do to kind of what would happen? You see, if we did this kind of model of going straight to PCR, or the version that we talked about of antibody and then reflex PCR, we would already reduce the number of infections in our community. And then if we kind of did annual testing of people in opioid agonist treatment, then we could really bring ourselves down below this kind of elimination rate. So this was predicted, in a few, this was obviously from a 2016 startup point where if we test everybody in drug treatment every year, and we test PCR and we facilitate treatment, we can really reduce the number of people in the addiction treatment world who have hepatitis C. I just wanted to kind of share a moment about the kind of notion of kind of integrating health services into both what we had done in the injecting room and what we can also do in our other contexts. So the other, the injecting room was and is a site of addiction treatment, of opioid agonist treatment. So there's a safe with kind of Suboxone, depot buprenorphine on site, and certainly in the, if you see on the website, you can see the tally of the number of people who've been initiated. More than 1,000 people have been initiated opioid agonist treatment with different forms of methadone or buprenorphine, and I think the majority with depot buprenorphine. And again, through by adapting what might be the kind of the treatment pathways to what might work well for this population, we were able to, I think, attract a surprising number of people into opioid agonist treatment. There were people who thought, this population are not here for treatment, they don't want treatment, they've just come to inject. But what we saw was that many people were open to it. They had just found it difficult to navigate the process of trying to find a doctor who would prescribe or a nurse practitioner who would prescribe, the process of kind of making appointments and the time it would take, and that we were able to offer it generally within 24 hours. Somebody would say, actually, I think I've had enough of this. And we would say, well, why don't you come and have a chat with somebody? And then we would generally initiate within 24 hours. And that simplified, streamlined pathway resulted in, I think, a more rapid uptake of opioid agonist treatment than we might otherwise have seen. And we used the same principles for other healthcare, but certainly prior to COVID, we implemented an oral health program, looking not just at access to the dental services at North Richmond, but the use of silver fluoride, which is a kind of on-the-spot temporary treatment of dental caries, which kind of reduces the pain, stops the hole in the tooth from growing while waiting for more definitive care. Wound care for people with kind of various leg wounds associated with groin injecting, accommodation services, mental health services, primary care services, food and drinks, activities such as the art project, all of these things we were able to integrate into the site at the injecting room, including take home naloxone as well, and identifying people who were genuinely really sick and needed to go straight to hospital. So while you can think, well, this was just a service for people to stop overdose, it actually had the capacity to do a lot more. And I think the same goes for many of our addiction treatment services, that we can provide other things at the same time. And I'd like to share one or two examples of that. So this is in a hospital in Buffalo in the US, in New York State, near the Canadian border, where they have similarly adapted their hepatitis outpatient clinic, which notoriously people don't show up for, and just turned it into a drop-in clinic. Anybody can present anytime and get their bloodborne virus screened. And then they recognized that many people similarly wanted their addiction medicine issues looked at. And so they formed a partnership between their hepatology service and the addiction medicine service. And they have treated more than 7,000 cases of hepatitis C. I think it's more than anyone else in the world. And just through making it very easy to access. And similarly, they've kind of made their addiction medicine treatment options, opioid agonist pharmacotherapy, very easy for people to access through this kind of just drop in, don't worry about an appointment, and then they have a flexible schedule, multidisciplinary team. It's a low barrier to entry. They have point of care machines that can diagnose Hep C within 60 minutes for same day treatment. And like I was saying, I think that this model has treated more than anybody else for their hepatitis C model. And so I think that's potentially something we can think about in the addiction treatment models that we're operating in more broadly. So just like to acknowledge all those who are involved in the work of testing and treatment of hepatitis C at North Richmond, and I'll leave it there, and happy to take any questions. Thank you.